All right, you guys are going to hate me, and I am so terribly sorry. Hold on. I just realized something. I didn't hit record. So I'm not happy. But I'll review it again. I'm sorry. All right, here we go. Share screen. Yeah, it did. I forgot. All right. I got so busy doing the Zoom that I forgot all about sharing it, or recording it. Don't worry, I'll redo a lecture on the neurogenic bladder, so don't panic. All right, so here's your scenario. You're working as a GIGU nurse on the floor. You receive a call from your affiliate outpatient clinic notifying a direct admission. And they have a woman that's 87 years old, 3-day history of intermittent belly pain, bloating, nausea, vomiting. She moved from Italy to the States, and his family's only 2 months, or just about 2 months ago. Speaks little English. So all the information's obtained through the grandson, past medical history, colectomy for colon cancer, ventral hernia repair 2 years ago, no history of coronary artery disease, diabetes, or pulmonary disease. She takes only ibuprofen occasionally for mild arthritis. Allergies include sulfa drugs and Demerol. Tentative diagnosis is small bowel obstruction secondary to adhesions. So they're admitted for diagnostic work. The vital signs are stable. They have D5 half an S with 20 milliequivalents of potassium at 100 mils per hour. They're on 3 liters of oxygen by nasal cannula. So based on the report, what signs of bowel obstruction did they manifest? So they had a colectomy. Hernia, belly pain, nausea, vomiting. Ibuprofen from, okay. So belly pain, bloating, or distension for 3 days. These are 2 of the primary symptoms of an intestinal obstruction. There are other signs and symptoms that you should observe for while they're in your care. And what are they, or are there? Bowel sounds, okay. So based on this here, so it says, are there other signs and symptoms that you would observe for? So stool appearance, okay. Board-like stomach, fecal smell. All right, so let's see. So other signs would be the fever, in the nausea, the vomiting, hypoactive bowel sounds or hyperactive bowel sounds, constipation, any signs of dehydration. So things that would support the fact that they would have a bowel obstruction. All right, page 2. So the grandson arrives, you admit them to a room, you introduce yourself, and the grandson's interpreting. She pats your hand. You know that you need to complete a physical examination and take a history. What should you do first? interpreter. Explain what needs to be done via interpreter, okay? Vital signs. Anything else? All right, so first you establish a rapport. Her patting your hand may be a cue. You may take her hand when you talk to her and address her. Don't look at the interpreter. Watch her condition. If she appears weak, you may have to wait to get your history. When she can think more clearly, cover the basics in your assessment first in case you have to wait until later for more detail. If she looks as though she can tolerate both, then get both. All right, so the grandson's an attorney. He tells you, you know, elderly Italian women are extremely modest and may not answer questions completely. So how could you gather more information in this particular situation? Rephrasing questions, okay? Be direct. So divide the history information into critical information and then the nice to know. So do the critical first and then the nice to know second. So what key questions might you ask this patient while you have the use of an interpreter? Last bowel movement, history, last urination, last BM color formed, any changes, last meal, any nausea, vomiting, diet. Okay, so determine the time of her last BM, last urination, color and amount of the stool, urine, when she last ate, cardiac, pulmonary, and GI problems, medications to allergies, double check medications. So remember, US brand names you're familiar with will be considerably different, and patients really are familiar with the generic names. So in addition, the drugs often have different appearances, color, size, and shape. We may need a foreign drug resource to, so check with poison control. Detailed questions about her pain. So we could use Caldera, like characteristics, onset, location, duration, exacerbation, radiation, relief, and associated symptoms. So we have that little note to self about using family members. So we should use the hospital provided interpreter phones, even if they do take a while. So we got that. So number 6, how would the description of their pain differ if she has a small versus a large bowel obstruction? Severe to mild pain, large bowel is persistent, crampy, gradual. Yes, small is a fast onset. Okay. So small bowel pain would have a rapid onset and is intermittent colicky, crampy pain that's usually relieved by vomiting. And large bowel is described as persistent crampy pain that develops more gradually. Good job, Amy Lee. Large can be a tumor or related to a tumor. That can happen. With some difficulty, you insert a nasal gastric tube and you connect it to low intermittent wall suction. How will you check for placement? X-ray, yes. All right, there's several different methods, but X-ray is the best and most reliable way. We can do the aspirate of the GI contents, so we're not pushing anything through, we're just gonna check the pH. So we're gonna skip on through that. List in order the structures through which the NG tube must pass as it's inserted. So what structures does the NG tube go through? Starts with the nose, the nasal pharynx, the pharynx, esophagus, and stomach. Nope, not the epiglottis. It'll be in the trachea if we go there. So the nares, the nasal pharynx, the pharyngeal area past the epiglottis, because it's actually going to be on the back side, because the epiglottis should actually what? Close. Okay. The esophagus, the cardiac sphincter into the stomach, but then we also have the low esophageal sphincter too. What comfort measures are important while she has an NG tube? Okay, tape it. Okay. Nothing, they're uncomfortable. Pin to gown, spray. So we could have done lidocaine spray, you know, beforehand, lean the head forward, provide oral care. All right, so properly tape it. Pin the tube to the gown. We already had that. Regularly observe and clean the nares, oral care, and then benzocaine spray or lozenges to help with sore throat. Help them turn in bed to avoid, you know, pulling the tube out, because nobody wants to put that in a second time. So the NG tube has not drained in the last 3 hours. What can you do to facilitate drainage? Positioning, okay. Check patency, okay. See if it's connected to the suction, irrigate. Make sure the suction is actually working. So check connections, make sure the tube is connected to the suction source. Make sure it's not kinked. Have them turn, check placement by gently irrigating. If it doesn't work, then irrigate with saline. If the air doesn't work, and then position the NG tube, change the position of the NG tube and retape it. All right, so now she puts out 575 mils. Then it slows down to about 250 mils over 2 hours. Is this an expected amount? Okay, so there's a question about mucus clogging the tube. If we have mucus, are we in the, do you mean like stomach contents when you say mucus, Miss Shelley? Or do you mean like loogie mucus? Because then we would be in 2 different areas. Mucus in the stomach, if it's lodged up towards the rugae and there's something material there, that can happen. But usually there's not mucus in the stomach though. If it is, then we got issues. Okay. So we have 50-50 that this is normal, and then we have a no. Any other thoughts? All right, the typical NG output is roughly 1,524 hours, but the GI tract actually produces more than 800 mils or 8,000 mils in 24 hours. So the amount of drainage from the gut will vary depending on where the obstruction is located. A sudden change in quantity should alert you to look at the canister more frequently and observe, and continue to observe for signs and symptoms of an obstructed NG tube. All right, so you enter AG's room to initiate your report. She's been hospitalized 3 days and her belly seems to be more distended than yesterday. Is that a good sign? So how would you determine belly distension has changed? How are we going to measure circumference? So we're going to get an abdominal girth to see if, you know, the tape is expanded from 25 centimeters to, you know, 50 centimeters. All right, so let's see. We're going to measure the girth, the widest point of the belly, and compare the number to those taken previously. So we should be getting abdominal girth sizes, checking bowel sounds. All right, so as the case study progresses, the NG, 3 days, after 3 days of suctioning, her symptoms are not relieved. She has nausea, cramps, strong stomach pain. Her hand grips are weaker. She seems to have more lethargy. Her lab values, compared to her admission data, went from 136 to 130. Potassium's changed down to 2.5. Chloride's 97. CO2's 31. BUN's 38. Creatinine's 2.2. Glucose is now 65. Albumin's 2.1 and protein's 4.9. So we have the sodium, chloride, potassium. Potassium's definitely critical. What about the BUN and creatinine? So that's not good. We're concerned about kidneys, okay? All right, so here, potassium, because they're losing it through the NG drainage, it's life-threatening, so they can go into cardiac arrhythmias. The protein and albumin are low, and they're indicative of malnutrition and poor liver function. Without them, the colloidal and ptotic pressure is decreased, and fluids leak from the cardiovascular space into the interstitial spaces. Mobilization of the fluids out of the cardiovascular space can now cause them to go into shock. So we need the proteins for healing. The elevation of BUN and creatinine is because of the it'll be now acute kidney injury, dehydration or increased protein catabolism because of the malnutrition. So they haven't started her on TPN, and her body could be catabolizing the protein for energy. The other electrolytes, the glucose, the sodium, and the chloride, could be due to the GI losses, and the glucose could be due to starvation. She's not taking any dietary daily calories at this point. Changes may rise from the NG tube losses, resulting in metabolic alkalosis. So we want to check magnesium levels. Okay, what measures do you anticipate to correct each of the imbalances described?
I remember when I was doing my wedding, I would come in here and get flowers on sale.
Okay, IV piggyback, are we talking about fluids? Okay, but we already have potassium, remember? She's already had D5, half NS with 20 milliequivalents of potassium. So we need to, the K will be diluted and given intravenous as a separate infusion. So she may need another K potassium or some more potassium. So the physician orders 40 milliequivalents IV piggyback. So we're giving her how much? 40 in one bag, and then she's getting 20 per her liter bag, right? So we're going to give her basically a bump of potassium. We're going to check her basic metabolic profile because the creatinine that's elevated shows that the potassium there's potassium excretion despite the fact that she has an NG tube. Because of the rate must be controlled, then the the KCL always infused via pumps, so we're not going to give that. Without telemetry, we can only give 10 milliequivalents per hour, so we do have to put her on a monitor. Albumin is not dangerously low, but if it was 1.5, the physician may give 25 grams of albumin. It provides the same osmolality as 2 units of fresh frozen plasma. Albumin is a volume expander, so it keeps the cardiac output up, and it actually mobilizes the fluid from the interstitial space back into the intravascular space. We could do the sodium chloride by changing the concentration of the maintenance IV to maybe D5 NS instead of half NS. We could do TPN via PIC, so that would give us the nutritional support. And all the abnormalities could be regulated by giving this nutritional support. Okay, so she's having slow deterioration despite all of what's being done. The surgeon comes in, releases an 18-inch section of proximal ilium that has been constricted by adhesions. Several areas looked ischemic, so they were excised, and an end-to-end anastomosis was done. So tolerated the procedure well, rapidly recovered from the anesthesia, and once on the unit, her recovery was slow but steady. She went home, and on the 7th postoperative day. So discharge plan are home health, health aid, physical therapy, dietitian consult. Any questions on that? Oops, hold on. There we go. Wrong spot. No questions? Oh, okay, no. All right, let's see if I have another one in here. And we'll do that. Found another one we can do. And this is a little bit of a shorter one. This actually has a couple in this particular, the one we're going to do next. So as I go through this particular case study, what I'll do is double back on the information that we covered earlier, so that way folks that weren't here don't miss out. That's about the easiest way I can back that one up. And I'll see if I can find a neurogenic case study as well. Neurogenic bladder, not neuro, and then we can cover that piece. Usually I'm pretty set on top of the recording. All right, so this is going to be we're going to have like a 4-part process with this next case study. So I think it'll still cover back everything that we covered earlier, which will be great. Yeah, yep, I think this is going to cover exactly what we needed. All right, so let me go back to the top, and then we will start with this next case study. Share screen. All right, so can you see that? Can everyone see? All right, so we have Mr. Cook, who's a 76-year-old African-American man admitted to the emergency room with pain in both legs. Aw, man, silly Millie. And he has had bypass surgery of his left femoral popliteal 5 years ago due to peripheral vascular disease. He's a type 2 diabetic for 30 years. He's been smoking 1 pack of cigarettes a day for 45 years. He has a weak femoral pulse and a right popliteal pulse with Doppler only. Right posterior tibial and pedal pulses are absent. So he's on a nitrate. That's what Isodil is, 5 milligrams daily. He's on a diuretic. He's on Lantus, and he also gets 50 units of insulin, Novolog, daily. Fish oils and Cardizem, which is a calcium channel blocker. So he also has what? What other health condition does he have? So he has he may not have heart failure, but he definitely has hypertension, diabetes, and coronary artery disease. So we have enough going on. So what risk factors places him at risk for PVD? That's going to be the smoking, the diabetes, the previous surgery, and his age. So all of those are going to put him at risk. Right, question 2, what other information do you need? Does he have peripheral arterial disease or peripheral artery disease? We're about to find out. So we're just talking about peripheral vascular in general is what we're speaking on. But there is definitely something in this whole situation where we don't have pulses. So what additional information do you need? We've already got smoking covered, we got diabetes, we got the surgery, we have his age. What else? I'd like to know the color of that foot, since, you know, he's had some surgeries before, a femoral popliteal bypass. Hair loss, good one. All right, so these are all the things we want to know: skin color, skin temperature, if there's any edema, the skin condition, vital signs, blood sugar, and allergies. Because remember, you know, diabetes can cause you to end up with some type of peripheral vascular disease or peripheral venous disease of some sort, right? All right, diagnostic test. What needs to be ordered? We could do a Doppler. So we already know there's no pulse there, right? So when we have to do something like maybe a sonogram or an angiography or something like that to see a venogram, we need something to see if there's actual blood flow, cap refill. So Doppler ultrasound, or Doppler or an ultrasound would be in order here. Pressure measurements, angiography, MRI, those would all be appropriate. So what are your top 3 nursing priorities? Tissue perfusion, okay, I like that. Managing blood sugar, okay. And that would be part of the tissue perfusion. Or are you thinking more vessel circulation, teaching about positioning? We're talking about nursing priorities. ABCs, well, there's nothing going on with his airway. I mean, that seems to, or this seems to be A-okay. Our issue now is lower extremities. So if this was your patient in clinical, this is, you know, say this is your clinical patient. Stop smoking is once we get home. Do we want to dangle the feet at this point with no pulses? Okay. Perfusion is for sure, pain management, blood pressure, and blood sugar management. So anything that's going to compromise circulation, those will be the things that's going to be our priority and focus. So when you're in clinical, your focus on your patient should be things that you see or you're going to be able to impart change on in the 10 hours that you're in clinical. So things you can manage or, you know, assist in managing is pain, perfusion by whatever exercises or treatment regimens or modalities that's ordered. You can monitor blood pressure. So you're going to make sure it stays within normal limits. Kay Gannon said give the medications as prescribed. Checking blood sugar levels, so the AC and HS for sure. So that would be all the things that you would focus on in your clinical time frame. What teaching would this patient need? Diet, smoking, stop smoking. Okay, exercise, foot care. All right. So all of those would be anything that's going to cause vasoconstriction. So those would be teaching that you would talk about. So the diet, the smoking, lifestyle. We can't do anything about age. I mean, age is a done deal. So we can't change anything about that. All right. Foot care, somebody had that. So good. So here's any questions about PVD? So earlier, what we talked about, can we put TED hose on an arterial clot? No. So signs and symptoms of having an arterial clot would be decreased pulses. So cold extremity. If it's a venous insufficiency, because that's what we talked about previously, then it would be, if it's a venous insufficiency, then we would speak more of warm and then swelling in the extremity. And we don't want to elevate an arterial clot because we don't want it to move, right? But we can elevate a venous to help with swelling. And we're not going to stretch feet. We're not going to do like the pedal pushes, because if we do that with a clot, it may dislodge. And then now we have an emboli moving around. So that's why we stopped doing Homan signs. So with the venous insufficiency that I had spoke about earlier, those were some of the things that we talked about, making sure we check the girth, making sure that we looked at the colorations on the leg. So if it's a venous insufficiency, then they usually will have discoloration towards the ankle area. They would have more pitting edema. If it was arterial, then they would have more mottling and absence of hair. So that's how you know the difference between your arterial and your venous insufficiencies. So with venous insufficiency, you can have pain with or without activity. We talked about intermittent claudication being a part of venous or arterial insufficiency. It's arterial. Okay, so let's look at, then we went from there to mitral valve prolapse. So here we have this guy who's tired, lightheaded, palpitations, chest pain. Mrs. Wayne, not a guy, but we have a lady. She states that she's even tired when she gets up in the morning. So she's had palpitations a few times for the past 3 months. And she's a type 2 diabetic. She uses Lantus daily, regular insulin sliding scale with each meal at home. So what other information do you need? So just kind of, okay, duration of palpation, okay. or not palpation, but palpitation. Anything else? Don't you want to kind of know her history a little bit? You know, if she's been drinking any caffeine, or, you know, what kind of chest pain it is. Does she smoke? Because mitral valve prolapse happens when we have straight leaflets. When do we normally get mitral valve prolapse? Are your leaflets straight? They're floppy, or they buckle. So the leaflets buckle or bow up. We want to know about heart failure, because we said that can cause it. But what happens in prolapse cord, we have buckling or bowing of the leaflets. Therefore, it doesn't close, and that allows for regurgitation to happen. And only about 10%, 15% of the patient population will have symptoms. But a hallmark sign of a mitral valve prolapse is going to be a late to mid systolic what? Murmur, a late to mid systolic click, and they will also have a murmur, okay? So the blood flow backs up into the left atria, or can back up into the pulmonary veins, or into the pulmonary system. So overall, it's idiopathic, but we did say from an idiopathic standpoint, it can also be genetic. It's also connected to Marfan syndrome and lupus. So those were some of the things we spoke about earlier. And Marfan syndrome is a connective tissue disorder that makes up arteries. We would ask about allergies, okay? So vital signs, allergies, her home meds, and then any other medical history. So anything that can lead to a mitral valve prolapse, like infective endocarditis. Do they have any arrhythmias, or any other, if they have heart failure, as we talked about, so things that causes a thickening of the wall. What documents do you need to take into the patient's room when you see her the first time? Consent forms, okay. What else? That's it. History and physical info, okay, I like that. All right, so history, vital sign sheet, INOs, nurse's notes, bracelet, allergy bracelet. And, you know, if these are all, this will be on your computer. So these will be the areas that you would be clicking on for your patient. What equipment? Yes. Are you going to bring Miss Hudson into the room? Oh, hey, you never know. You can bring Miss Lily in the room. Okay, so what other equipment? Dynamap, stethoscope. Okay. Glucometer, thermometer, pen light. So the patient gown, no skid booties, and then just basic, this is all kind of first level stuff. This is, you know, just your basic stuff to bring in there. What diagnostic tests would you think would be ordered? What did we say we'd probably do? We definitely want to get some labs. Echo. Echo would definitely be a good thing. So an echo, a 12 lead, if they're short of breath, maybe ABGs. Okay. So we have a mitral valve that's been, or prolapse that's been confirmed. What assessment findings would you expect there to be? So we talked about palpitations. We talked about chest pain, shortness of breath, dizziness, feigning spells or reporting of feigning, and then fatigue or activity intolerance, right? That's what we talked about earlier. We already talked about the mid-systolic click we would expect to hear, and then we also talked about the murmur that we would be looking for. The regurgitation does make, it's kind of like it does make a sound on echo. So, so a murmur is basically, so the murmur is like a harsh blowing sound. It's like turbulent blood flow. And it's actually caused by a disruption of the blood flow. It's like a swoosh into the heart, between the heart chambers, or from the heart into the pulmonary or aortic system. So those two things are your hallmarks when you're looking at MVP or mitral valve prolapse, which is the late to mid systolic click and then the murmur. All right, so we fatigue, shortness of breath, all of these, the click, the regurg, and the mitral murmur. All right, so here's part 2. These are her vital signs. You hear a mitral click and a grade 3 murmur. Okay, so don't get stuck on the grade 3 murmur. Just understand there's a murmur. And then finish, and then read the rest of it. So she has IV fluids, half an S at 75. She's on a 2,400 calorie ADA diet, bathroom privileges, oxygen. And then we're doing blood sugar, AC, and HS. Is her pulse rate A-okay? Nah, I like the German. No. All right, blood pressure is high or low? So we have what's going on with her blood pressure? Okay, blood pressure is low. So that's a concern too, okay? All right, so the pulse is tachycardic and irregular. And it did say that 120 and irregular, so I'd be worried about that. Respirations are tachycardic. Her BMI, I didn't see that one. I may have skipped that. I don't know if that was earlier on, but looks like she had, her blood pressure is borderline. So those are definitely issues. Is there anything about the doctor's orders that you should question the doctor about? And if so, why? I haven't seen the doctor's orders yet. So the IV fluids, okay. Volume issues, like that. So depending on the patient's blood sugar level, the IV solution may need to be changed. The 2,400 calorie diet may be too many calories, and we should probably drop that to 1,800. So she has bathroom privileges. That's what the BRP is. She will not have much activity or exercise. What additional lab value do you think you might end up getting? A BNP, okay. CBC, yes. Ejection fraction will be a perfect one, okay? So we want a basic metabolic profile. Somebody had that up there earlier. Need to know her electrolytes, her glucose, her kidney function. Low perfusion pressure can also cause decreased blood flow to the kidneys. A CBC, so we want to get her H&H as well. So those are all good ones. Platelets can be damaged by the valves malfunctioning. All right, here's our next piece. So we got a little bit of a temp going. Pulse is still up and irregular. Vitals have dropped, but now we have another problem. What's our next problem? The pulse is still high. Her chest hurts. I mean, her oxygen sats. I mean, she's now having more problems than before. Okay, so is there any information we need to know? Nope. We need to get more details about the chest pain. When did it start? Characteristics, how long does it last? When was it brought on? Was she doing an activity? Does she feel short of breath? So all of those will be next. All right, S-bar, you guys' favorite thing. What does the S-bar mean? Situation, background, assessment, recommendations, right? So we need to be able to communicate her whole process. How do you organize your information? Vital signs, well, basically introducing yourself, telling him who the patient is, how they came in, what's their backstory, then give them this information, the concerns, restless and chest pain, decreased breath sounds, cyanotic nail beds, she has a murmur, a click, blood sugar of 250, she can possibly have infection, and remind him about the IV fluid orders. Okay? So what concerns do you have about the new assessment data? SATs are low, so this is part of your S-bar still. She's still tachycardic, tachypnic, and she's still complaining of chest pain. So what do you think changed or caused these changes? Her mitral valve is causing heart failure. So we talked about heart failure. You know, the BNP should be less than 100. If it's greater than 400, then that's significant for heart failure. If it's between 100 and 400, then we just need to consider doing additional diagnostics. So we could do an ejection fraction. We talked about normal ejection fraction is between what? What's our normal? 50 to 70. So if it is 35, is that good? No, that's terrible. Okay. That means, what does it mean if it's 35, or what does it mean if it's 25? What's happening with our perfusion? Is it good? Nope, we have low perfusion. So those were things that we covered earlier. Okay, so what is the priority? What's our priority here? Oxygen, okay. Fluids, trying to get that extra fluid off. Okay, so oxygen, SAT, shortness of breath, chest pain. I'd be more concerned with the oxygen or the chest pain, or both. Chest pain because it could lead to respiratory problems. So good, Bertha, good, Amy, good, Kay. And then the oxygen is critical. So those are going to be the biggest things we're going to focus on. All right, so this is break you up into groups. This one actually tells you what the grade of the murmurs are. You're not going to be tested over it, but you can just see what the grades are here. Now that I am recording, unfortunately, I didn't do that earlier. Someone asked, how relevant is left-sided diastolic dysfunction, in this case, significant? I mean, the left side is what pumps out everything. So if it's not working, then we're going to have huge problems. So it's very significant. Other characteristics of murmurs, just in general, and this is just because someone asked that question. So it's the timing in relationship to your lub-dub. The quality, these are the different types of sounds you could hear. You know, you can have it go through the back of the axilla. You can have murmurs disappear with position changes. The click, it sounds, you know, again, mid to late systolic. It's short and high pitched with the click quality. So that's kind of the definition. This is a little bit about mild to severe regurgitation. And these are just kind of terms to follow back up on. So the echocardiogram evaluates ventricular function. It can look at the motion. It actually tells you how the blood flows through the heart, if it's going through really well, if it's stagnant, if there's stenosis or whatever it may be. So treatments for MVP is a valvuloplasty, a valvotomy, and an annuloplasty. So an annuloplasty basically tightens up the malfunction valve to eliminate or reduce regurgitation. The other treatments would be hydration, regular exercise, and to avoid caffeine. Complications that we talked about was a thrombus, so they need to be on anticoagulant therapy, especially if they have a prosthetic valve. And anytime they go to the dentist, they're going to have to be placed on prophylactic antibiotics before any invasive procedures or dental procedures for 6 months, and work on their oral hygiene. Medications that we can give them, we talked about beta blockers, and to decrease their or to control their palpitations. We're not going to put them on nitrates because nitrates won't work. They cause vasodilation, and we don't have a vasodilation issue. Our other teaching would be for them to have a healthy eating habits or healthy diet and avoid all stimulants that's going to exacerbate signs and symptoms of prolapse, so, or cause palpitations, like diet pills, caffeine, ephedra. And if things get worse, if they have terrible palpitations, fatigue, or shortness of breath, then they need to contact their primary care physician. So here's the medications again. Someone did talk about DIGE to slow and strengthen the heartbeat, Lasix to eliminate, and this will be now because of the heart failure, not because of the mitral valve prolapse. So I don't want to confuse those. Okay, so now that we have heart failure, we're actually treating the heart failure component before we even deal anymore with the mitral valve prolapse. Does that make sense? Yay, nay? Okay, so everything in number 9 is only related to heart failure. So we can give them DIGE, we can give them Lasix, we can give them nitroglycerin, morphine. We won't do antibiotics. Beta blockers, we talked about that to decrease. Now that part would be for the palpitations. But remember, the parameters for giving beta blockers, you need to check heart rate and check blood pressure. We don't give it if the blood pressure is like low 100s, and we don't give beta blockers if the heart rate's less than 60. So other treatments that could benefit her would be to put her to treat any arrhythmias she may have and give her lidocaine, but that's kind of advanced for where we are. But you don't need to know that. DIGE basically increases the contractility of the heart, and at the end stage, it is treated with mitral valve replacement. So it's not something in the beginning stages. We talked about regurg. So because of the floppy leaflets and that they're incompetent, then you can have regurgitation that can happen. So during systole, the blood doesn't move forward to the aorta from the left ventricle, and this can lead to cardiogenic shock. So anything that causes left ventricular enlargement, it stretches the heart and causes the mitral valve to no longer come together appropriately. So things that can cause a regurgitation would be changes in the tissue of the shape of the heart after someone has a heart attack. So especially if they have left ventricular failure, if they have disease of the heart muscle itself, so cardiomyopathy, then they can end up with regurgitation. So there's 2 different types of cardiomyopathy. One's ischemic and one's non-ischemic. An ischemic cardiomyopathy is related to coronary artery disease, or it dilates the heart to compensate. And then non-ischemic would be genetic, alcoholism, and toxins. Other things that can lead to mitral valve prolapse, or that can cause regurgitation, is mitral valve prolapse, rheumatic fever, endocarditis, which is a vegetation on the valves, and papillary muscle dysfunction or rupture, calcification around the valve so they won't close effectively. So all of those things would be related to MV, to mitral valve regurg. We have an acute and a chronic phase. So acute means the papillary muscles ruptured because they had a heart attack. So it led to flash pulmonary edema or heart failure. And then chronic regurg is related to dilated ischemic cardiomyopathy. So if they have regurg, then you'll see things like fatigue, dyspnea, the same signs and symptoms almost that you see with prolapse. Pulmonary congestion, left atrial enlargement, thready pulse, a loud holistic, holistic murmur. So we auscultate for the, how do we auscultate for our mitral valve? Where do we hear that sound? Let's see if we remember that from earlier. Fifth intercostal space, mid-clavicular, thanks. So the other things you can hear is a S3 gallop, peripheral edema, and cool, clammy skin when we do our assessment. So if you have acute mitral valve regurg, that's going to be poorly tolerated. So the patient does not tolerate that appropriately. All right, so what's the rundown with neurogenic bladder? Let's cover that real quick. I'm going to switch gears, stop sharing. And so when we're looking at neurogenic bladder, so let's see, bladder training. So we definitely want to do that every 3 to 4 hours, right? So causes of neurogenic bladder, what were our top causes? We had several of those, right? Trauma. So when we're talking about trauma, we're looking at spinal cord injury, multiple sclerosis, herpes infection that's around the sacral area, stroke, a brain tumor, Parkinson's disease, herniated discs, pelvic surgery. All of those can lead to neurogenic bladder. So complications would be incontinence, urinary retention, urinary tract infections, kidney stones, and kidney failure. So they have a history of UTIs. They have a history of maybe having hyperactive autonomic reflexes. That's where the bladder's distended, at the lesion of the upper thoracic or cervical level. So we can have that. Usually what's injured on the spinal cord is above T12. So stress incontinence, hypertension, bradycardia, all of those were signs and symptoms that we talked about earlier. Increased anal sphincter tone. For imaging or labs, we talked about getting urine and blood or urine cultures and then checking BUN and creatinine to see how the kidneys are working. The retrograde urography looks at the strictures and diverticula. They can do an ultrasound of the kidneys. They could do a cystogram or cystoscopy. So all of those things are looking at urinary flow. We talked about avoiding stimulants, avoiding spicy foods, alcohol, avoiding foods that are citrus or citrus fruits, stay away from chocolates, caffeinated drinks, carbonated drinks, artificial sweeteners. Outside of doing the bladder training and emptying every 3 to 4 hours, we also talked about pelvic floor exercises or the Kegel exercises. Name some medications they can take. Vesicare, okay. Enablex, so ENABLEX, Ditropan, Detrol, those are all designed to decrease bladder spasms and control overactive bladder. Elavil, thank you, Kay Gannon, I was just getting ready to go there. That's an antidepressant that we can use to help treat bladder dysfunction. They could do surgery, so they can have an external sphincterotomy, urethral dilation or urinary diversion. They could have a bladder neck suspension, bladder augmentation. Those were all the things that we talked about. So we may have to do self-catheterization, right? And we don't want to take more than a half a liter of urine at one time. So talk about absorbent pads, provide support, talk about how not to end up with UTIs. So by emptying the bladder, that will definitely help. So let's see, what else was there? Assess their anxiety levels. Do INOs. And there was someone posted up about perianal care, making sure they don't have any skin breakdown and prevent decubiti. And then seeing their neurologist to continue supporting the bladder training. What else? Did I miss anything on that? Or did I cover it all? Because I want to make sure that everyone that wasn't here get a chance to, or an opportunity. Alcoholism, we want to avoid that, yes. All right, so that was prolapse, mitral valve prolapse, neurogenic bladder. Then we talked about hypertension. We talked about the, what's the, and this is, it's more insidious. So we always will be concerned with our target organ damage. So insidious means by the time signs and symptoms are seen, permanent damage has already occurred, right? So if we're, our goal is to make sure that our end organs are not damaged. What else did we talk about on high blood pressure? All the different medicines we can take, Lasix, beta blockers, ACE inhibitors. What else about ACE inhibitors did we cover? You guys remember? Or you were just like, she's droning on and on. Dry cough, heart rate, okay? Someone wants to know about case sparing. Okay, case sparing with ACE inhibitors and beta blockers. In what way? Usually if you have a beta blocker or an ACE inhibitor, you're going to have non-case sparing. It'll be the thiazides. So you can use them with thiazides and digoxin. It depends on the patient. So the question is, when do you use them together? So the doctor usually starts someone on like a thiazide, like Lasix. And if that's not working, then they'll add either an ACE inhibitor or a beta blocker, depending on the patient. But usually the beta blocker would be like a atenolol with HCTZ, which is the hydrochlorothiazide. So that's going to be patient and patient dependence on how well it works and doctor preference. So I can't say that this person's going to get, a beta blocker with a thiazide. It just basically depends on, their blood pressure, how high it is. That's going to determine which one of those they get and which one has been proven to work best. Does that make sense? That's true. We don't know, even if we just do the regular diuretic, we don't know if the patient's going to be compliant or not. I mean, we're hoping that they will be. We did talk about the B-type natriuretic, which is brain, peptide, the BMP. So we've already covered that. I just want to make sure I'm looking back through my notes of things that had little check boxes on. So I did talk about if you were to give somebody, an ACE inhibitor with Lasix, then we want to make sure that we auscultate breath sounds. And what would we expect to hear if we were using it to treat somebody with heart failure? What would you expect to hear with the auscultation? The crackles should diminish, correct. So that would be things that we would be looking for. Are blood pressure medications long-term or short-term? They're long-term. Okay, I covered that. We talked about the positioning. One thing I think that was not on there is when you're auscultating for mitral valve we're trying to auscultate the mitral valve, then what we're going to do is we're looking at the fifth intercostal space midclavicular. But if we are auscultating, then we're going to go APTM, and I say ape to man, because the A, to listen to the aortic valve sounds, and it would be the second intercostal space, right sternal border. If you're looking for the pulmonic, it would be second intercostal space, left sternal border. And if you're looking to auscultate for the mitral valve, the tricuspid valve, that's going to be the fourth intercostal space, left lower sternal border. Thank you. And then mitral will be the fifth intercostal space. So the auscultation works completely different than if you're being asked, where is the location? So if they're asking you the location of how it falls when you're tracing a drop of blood through the heart, then it would be TPMA, toilet paper my assets. Then if we're auscultating to hear the sounds, then when we go ape to man, which basically makes a Z pattern formation if you map it out on the torso. Back to hypertension as an overall, we talked about making sure if we had platelets that were like 20-something thousand, we would be worried about HELP or the patient developing clots, so that would be a concern. We also talked about calcium gluconate. You know, that's our antidote for what issue? For mag sulfate. So if we have too much mag, then that will be something that we could look at doing. If your patient has any absences of deep tendon reflexes and they're getting a magnesium drip, what should you do? Stop the drip first. Absolutely. Don't keep it going. That'd be kind of crazy. So we did talk about compressions on the legs for arterial or venous stasis ulcer. When should we use compression hoses? On the venous side, okay? Concerns with hypertension in pregnancy. What's the, not the worst thing, I mean, this is not eclampsia or not preeclampsia or eclampsia, but more so how it can impact the fetus. Premature labor, exactly. So we talked about signs and symptoms of eclampsia and preeclampsia. Preeclampsia with the blurred vision, the headaches, the swollen feet, the halos, protein in the urine, and the difference between pre and eclampsia is now we have seizures that we're adding in addition to that. Who remembers the volume weight gain in relation to someone with heart failure? Because we know hypertension can cause heart failure. So if they have 3 pounds in 2 days, so 3 pounds in 2 days and 3 to 5 pounds per week. There we go. So we did talk about that. Can you use a heating pad to help with peripheral arterial disease? No, so don't do that. Just checking to make sure we can use that for venous though, can we not? Can we use it on venous? Decreased sensory. Is that for which part is decreased sensory? Arterial or, okay. So no, we're not going to use it on the arterial because it can lead to them having burns. Okay. Someone said, why no heating on arterial? Because of decreased sensation to the feet. We have decreased circulation. So if we add that heat, we could actually be burning their feet instead, and we would not know it. If we're given blood pressure medication, we talked about the side effects. We need to tell our patients when to call. So what would be the side effects? Dizziness, and we're running the risk of them having what? If they get up too quick, then we'll have the risk of them falling, and we don't want that to happen. We talked about making sure you know the levels of your HDLs, your LDLs, your triglycerides, your chlorides, your BMI. All of those things are, those are those labs back from nutrition that you're still responsible for. Let's see. We talked about critical rhythms you need to know. So the arrhythmias. Someone said the 1, 3, 5, and 8 in your PowerPoint, but it was VFib, VTach, asystole. You need to know sinus rhythm. You need to know sinus tachycardia, sinus bradycardia. Those are not criticals. Those are your just standard rhythms. Those are your basic rhythms. We went through the ECG conduction. So what node is first? The AV node, SA node, then the AV node, the bundle of His, the bundle branches, and then the Purkinje fibers. Good question, Will. How to count the ECG? I didn't cover that. So we're going to do the R wave to R wave, right? And we need to have a complete complex in order for it to count. We're not doing the tiny boxes, not for the heart rate, no. But you can use the tiny boxes to determine if your PR interval is within normal limits, if your QRS is within normal limits. Then you will use those tiny boxes. Back to your question, Ashley, you do calculate your R to R. So if you have 7 R waves and it's a complete complex, it has a P, a QRS, and a T wave, you will multiply it by 10. So that is correct. So I'm not sure about the JK if it means just kidding, but that was actually correct. We talked about what represents atrial depolarization. That would be your P wave. Ventricular depolarization is your QRS. Ventricular repolarization is what wave? That'll be T wave only. And then the atrial repolarization is hidden in the QRS. There we go. So what if your patient had a hard abdomen? Would that be normal? Okay, so if you got that in your shift report, we should be thinking obstruction. We also talked about, okay, peritonitis, it could be a rupture, because that would be more of your issue. So with diverticulitis, we talked about things getting trapped inside. They can have in the diverticula. We talked about foods we would encourage them not to eat. So all the things that have seeds like cucumbers, nuts, seeds, tomatoes, kiwi. So all of those things they would need to stay away from. Raspberries, strawberries. We had all of those listed in there. We also talked about the reason why diverticula comes into play related to canned goods. It kind of slows down things. The diet, having a low fiber diet, so really no fiber. But during the acute phase, we talked about why we would not use what to test? No barium enema and no colonoscopy, because that can lead to perforation. So we talked about not doing that. As they begin to recover, during that acute phase, then we're going to rest the gut. That's our goal. And then they're going to have that NG tube in to decompress the stomach. And as we start to have them return back to, or as they're recovering, as they progress, we're going to go from clear liquids to a low fiber diet. So that'd be like your white rices, your vegetables that have been peeled, cooled, and skinned. So we talked about those, and then we'll then transition them into a high fiber diet. So that's kind of the weight of how that works. We also looked at Crohn's disease. And so we talked about the skip lesions, some of the signs and symptoms, the explosive diarrhea. We talked about the inflammation that happens with Crohn's. We talked about how to treat it. So all of the different medicines that are involved with treating Crohn's. The signs and symptoms would be the colicky abdominal pain, the inflammation or possible stenosis or stricture, but the belly pain would be right upper quadrant. They may have the diarrhea that can contain pus, blood, or mucus. Weight loss, malnourishment, malabsorption because we're losing the tissue to absorb electrolyte imbalances, fissures, fistulas that can happen. So that was all some of the signs and symptoms: fever, malaise, nausea, vomiting. The medications were the aminosalicylates. That's going to be is that our first line of treatment? And if so, for which type of Crohn's? Right, that's the sulfasalazines. It's an anti-inflammatory, and we're going to use that for severe Crohn's, moderate Crohn's, or mild. We're going to use it for mild, and we don't give it if the patient's allergic to sulfa drugs. So this is going to help to prevent flare-ups. And if that doesn't work, then they're going to add a steroid, right? Right. Concerns with steroids would be infection, osteoporosis, hyperglycemia. Then we would look at our immunosuppressors, so like our Imuran or our tumor necrosis factor blockers. We would look at that. Antibiotics like Cipro, antidiarrheas, and we're not going to give them any NSAIDs because that can also lead to or cause additional damage to the lining and GI upset. How do we know if we have a fistula? Probably we're going to have fecal smelling urine, so that's how you know that the urinary tract and the bowels are now connected. So we are concerned about bowel rupture or peritonitis, and then we talked about a paralytic ileus, basically means peristalsis has stopped. And then we talked about the difference between mechanical and non-mechanical obstructions, right? We can also, what type of dietary, other dietary measures for UC will we consider? Folic acid, vitamins, we talked about B12, iron, what else? High protein. Okay, no salt, but we talked about high protein, didn't we? As some other dietary measures for that condition. Did we miss any for the insufficient calories? So we need the B12 or cobalamin, foods high in folic acid, high in vitamins, and sufficient calories and proteins for those individuals. Let's see. We talked about that. I think I just covered that. Hold on. What is one electrolyte imbalance that we would be concerned with Crohn's that would be critical? Hypokalemia, exactly. So we even talked about that even just a minute ago. We talked about if you see someone on the monitor that has ventricular tachycardia, what's the first thing you need to do? Check the patient, check a pulse, then call a code if it's the patient is pulseless, right? Okay. I think the last thing we talked about before I had that massive brain infarct and not starting the record button was what concerns do we have with statin meds? And it was myopathy, and it had to do with, and I believe this was Amy that brought that forth. It is muscle pain, but it has to do with the reductase enzymes and how it breaks down the muscle tissue. And it could lead to a serious condition known as rhabdomyolysis. All right. I think, and correct me if I'm wrong, Was there anything else that I talked about previously that I didn't bring up before? You're all like, I don't know. Let's see. Oh, hold on, trying to get to comments. Let's see. Oh, that we don't leave our patients. Yes, yes, yes. Oh, it's going on about 17 days. All right. All right. We don't leave the patient. So we call the code, we put the patient down, and we start chest compressions. That is what I talked about. We start chest compressions, and hopefully somebody else will come in there and start bagging for us. But we definitely do our 15 to 2. Is that the ratio? Yep, staying alive, it's 30 to 2. Exactly. Just checking. You all have those little blue cards, those, basic life support cards. I want to make sure you know what you're supposed to be doing. Okay, I think I kind of, even though it was a little unorthodox, I apologize for not starting record early, but hopefully now we have everything of what we need. We're not doing ulcerative colitis, so don't focus on that at all. You're just responsible for Crohn's disease, you're responsible for diverticulitis, you're responsible for the the obstruction, the paralytic ileus, so you're responsible for that. So thank you, Amy Lee. Yeah, my brain was actually starting to fry. So I'm glad that you got that piece. All right, guys. So go ahead and be fruitful on this study, and we will see you Monday. You guys are very much welcome. It's been my pleasure. All right, we'll see you Monday. You're welcome. You're welcome. You're welcome. Thanks, Karina.